Welcome everybody. Welcome to the Focus on an ALS session. My name is Jaz Saur. I'm an intensivist in Bristol. I'm also the chair or co-chair of the ALS Science and Education Committee for the European Resuscitation Council and the chair of a programme committee for this session. So for those of you who just joined, this is a Focus on ALS session. Before we move on, you can use the Slido function to ask questions of the panel during the session, and they're all going to give brief versions of their talk during this session, and longer versions are available to watch afterwards if you scroll down. And the other important thing is that the ERC has just put out its draft guidelines, and those are all also available to look at. And where, for the first time, we're going to allow the general public, healthcare professionals to feed back on these guidelines. And based on your feedback, we may update them and change them. It now gives me great pleasure to welcome my co-chair, Kate, and over to you, Kate.
Thanks, Jaz. Hi, everybody. I'm Kate Berg. I'm also an intensivist in Boston, Massachusetts, in the United States. I'm happy to be joining you guys from the other side of the ocean. And our first speaker is Dr. Therese Jarve, who I'm pleased to introduce. She's an emergency medicine and internal medicine physician in Stockholm in Sweden. So welcome. She's going to be talking to us about prevention.
Okay, thank you, Katie. So I will have the honor to talk about prevention, and that's my favorite topic, and I will do it very quickly. So how doesn't work to change the slides? I don't know why. I just need to check. So sorry about that. I need to share again. So my conflicts of interest is this. And the new guidelines has bullet points on prevention. 8 are in hospital, and I will focus on that, and I'll tell you why. Mainly, they consist of having an early warning score system like NEWS or something, then you would fulfill many of them. So simple as that. Yes, it is as simple as that. But the problem is still around. Every day in the US, there's a number of patients corresponding to 2 full airplanes of in-hospital cardiac arrest while there are patients, while they're in hospital, among staff that we can train. And that's why I think it's important to focus on prevention in hospitals. We can't have it like this. We need to be a little bit curious about this, and I'll do better in the future. What do we know about this? Well, this is a nice picture of Charles, who changed the size of the circles in the chain of survival based on where most patients actually are. So in Sweden, we put in 2,500 each year. We can only get 750 out. Not a good deal. And this is despite the fact that we are in circle number 3 within 3 minutes for the majority of the patients. We can't do that better, but I think we might have forgotten this part of the chain of the survival. So we can't put signs up, don't enter, even if that would be my dream. We can't put walls up. So what can we do? I think we can do this. We can find vital signs, and we can take ethical decisions. Why do I say this? So there's a lot of articles out there. This one is from almost 20 years old, and this is a new one. If you focus on the numbers, you can see that a lot of the cardiac arrests in hospital are avoidable. Looking at them afterwards, of course, but if you look at them and you can see that the blood pressure is not coming up, and you can only see when you look at it afterwards that this is the way it's going to be. Therefore, we have to use this as a sign. Either we can treat it, or we have to go and talk to the patient. That won't be simple at all, but we have to do it to discuss with them. How are we going to handle it? What kind of care can we give you right now? How do you see your situation right now? So I think that would be one thing. So again, simple as this. Yes, it is, but nothing changes if nothing changes. We have been knowing about this, the early warning scores, the vital signs, the ethical decisions for at least 20 years, but still we have too many in-hospital cardiac arrests. So this is my question to the audience. Do we really teach and train good enough? I think all of us to talk about this during CPR courses, but do we do it in a good enough way? Is it like saying you should do CPR, but not practicing? I think that's what we do many times. So I think that how do we do this better on? It's up to you now, because we've been talking about this so many times. My take home is this. We can't accept these planes coming every single day. We have to stop it. And that's my bullet points for now. Looking forward to your questions and your comments on how to train this. Thanks.
Thank you very much for that summary and for your pre-recorded talk. Also, I'm waiting for questions to come in on the Slido, but I had one question for you. So at my center in Boston, we had looked at this specifically in the ICU, I think, which is a paper that you put up there briefly, and it was a very small number of patients. And as you pointed out, we did find that, both by an expert panel reviewing and by surveying the clinicians involved, that people thought a significant percentage were preventable, at least partially. Since then, we've tried to build an intervention to try to decrease preventable arrests in the ICU, and have been struck by how difficult it is to move the needle. And I guess what I wonder, looking at the literature overall, is that all the news and all the other scores primarily focus on finding the at-risk patients on the medical wards, and often their outcomes are sort of a combined death or transfer to ICU. But I just wondered if you have any particular thoughts about if in the US half or more of in-hospital cardiac arrests happen in the ICU. So how can we either build a score that works for ICU patients, or I guess, is there some other way we can target that preventability specifically in the ICU? Or do you think, as you also point out, that maybe those patients who are already so highly monitored that really we just need to be making those ethical decisions and making more people DNR before these things occur?
Very interesting. So I know this. I agree with you. In Sweden, we have most cardiac arrests like in high dependency units or things like that, when they are monitored and the staff is trained, but still this happens. And I think as long as it happens, we have to look at each case and discuss, why didn't we act upon this sign before? Otherwise, we won't know what to do. I don't believe in scores. I do believe in the personnel, that we need to train the staff better, because they are under monitoring. They are in the ICUs, in the high dependency units. So, and we have to be aggressive with vital signs, actually. I think we should train this. Like, I love in situ simulations, then we will understand, why don't you act upon this sign now?
I do see another question in the Slido. It says, let's see, how do you balance the need of extended monitoring for persons with risks and the need for resource ICU beds?
Yeah, this is also a thing. Like in an individual patient, it's very tricky to understand and solve. But if you look at this as a system, you follow up every single cardiac arrest, every single patient that don't get monitored and got an accident happen, then you have to see a system in it. And I think that's the systematic approach. And I should do it in my hospital and you in your, and I think we should compare data with each other and see this is a problem for real.
Yeah, agreed. Let's see, another question coming in. Thank you for a good presentation. And it says, is news really the best way to catch the cardiac arrests in time, or should we look towards continuous monitoring?
Yeah, a good question. Again, depending on resources, of course. Like in my hospital, every single patient have their vitals taken and documented, and we still have cardiac arrests. So, and for those who have VT or VF or asystole, it might help detecting. But for pulseless electric activity, it's not that easy to detect them.
Mm-hmm. Yeah, and I know at least in the US, there's a lot of trouble with continuous monitoring of various kinds, a lot of alarm fatigue also. So people tune out all of the automatic alarms. And I know there's been some interest too in sort of machine learning algorithms to go beyond the data that gets incorporated into the news. So some people are working on that as well.
Yeah, again, but the thing is also, a lot of patients are very sick. In ICUs, in high dependency unit, they are there because the vitals are deranged. So we need to look at the cases and find what's common in the cases, what's actually happens to all of the cases. Because if you start looking at all the blood pressures, that might be the wrong way to go, because all of them are there because they have poor blood pressure.
Mm-hmm.
I think we need to look at cases, and I think we should maybe review each other's cases. That would be one way.
Yeah, I think having done that in our hospital, it's definitely, yeah, you can learn a lot from reviewing all of those cases in detail. But I think your point about getting centers to share that data among themselves so we can learn from each other, I think is important. Jazz, do we have time for one or two more questions? There's a couple more on the chat.
Yes, yeah, I've got a question for you, Teresa. And clearly, how early can you predict? And one of the problems is that we can often predict people who are at high risk, but we still can't prevent their cardiac arrest. And what's the best tool available at the moment to do this?
I don't know which the tool is the best, and that's the problem. If we would know this is really a true risk patient, or this is just a patient signaling with tachycardia again and again and again, we would know this. I don't know what the best tool is actually.
But is there specific combination?
Staff is training.
Is there specific combinations? If you're this age, you have this diagnosis, and these, because the problem with the new score is it's only looking at vital signs. It doesn't look at the age of the patient or their diagnosis.
Yeah.
So combining those, is that the way forward, do you think?
Might be. I think we know too little about this, and this might be something for machine learning actually to find out.
Yeah, I agree. And there was a question in the chat also about artificial intelligence, which I think gets to the machine learning question. And I know, there's some groups that have been working on that, and some studies that have shown that those algorithms are better at discriminating at-risk patients than the early morning scores by themselves. I think
I was going to ask one more question, and then we'll go to the poll. Do you think it's a cultural thing? Because lots of hospitals use these scoring systems, but it's the culture of the hospital and how it responds to an abnormal score that is important. In that, is there any data on that?
I'm not sure about the data, but I guess there are, because the thing is that the response is very important. Like if you do news and you get 5 points, should you call someone or can you call someone? And when you call, should they just say, well, it looks nice, or should they actually come and check the patient? And that is how strict can you be with your system?
Okay.
Yeah, I think one thing we found in our data was that nurses and residents, so trainees, were almost always aware if there was a clinical change before a cardiac arrest, but the attending or the supervising doctor was aware a much smaller percentage of the time. So just thinking about, institutional communication and culture, that's one thing that we've tried to change.
Yeah, that's good. Yeah, there's a new study actually from UK, I think, about this, the staffing of nurses and assistant nurses. And they're more cardiac arrest if they are assistant nurses instead of nurses also. So it might be interesting with culture and competence.
Mm-hmm.
Okay.
Jazz, there's a couple other questions in the Q&A on Slido. Do we have time, or should we move on and come back to those if we have time at the end?
I think we should move on. Did you want to just tell people about the poll results? Okay.
Oh, sure. Yeah. So the 144 people have answered this poll. So that was the question, for those of you who haven't seen it, is which early warning score criteria does your hospital use? About 48% of people said news. 21% said they do not use a score. The 17% for the modified early morning score, and 8% other, and 7% MET, which I presume is medical emergency team.
Right.
All right.
Thank you, Kate and Teresa. We'll move on to our next speaker now. It's Professor Charles Deakin. He's an honorary professor of resuscitation and pre-hospital emergency medicine in Southampton. He's also got lead roles in the ERC, the Resuscitation Council UK, former ILCOR chair. I'm going to let Charles give us a brief update on the talk he's pre-recorded, and this is on defibrillation for cardiac arrest. So thank you, Charles.
Yeah, thanks, Jazz. Can you hear me okay?
Yes, we can.
Great. So good afternoon, everyone, or good morning or evening, wherever you are in the world. So I've just been asked to say a few words about defibrillation, and thank you for your introduction, Jazz. As Jazz has mentioned, there's a much more detailed talk that I've pre-recorded. So I'm just going to give you the bones of it in the next few minutes. I'm hoping we might be able to show some slides, just my summary slides. Thank you, perfect, that's great. So in terms of defibrillation, obviously it's a key aspect of both basic life support and advanced life support, but it's only of relevance to patients in shockable rhythms. Having said that, about 20% of patients present initially with a shockable rhythm. So only about 1/5, but it's patients in a shockable rhythm generally who go on to survive. So defibrillation is absolutely key in terms of optimizing outcome for these patients. In the recent Paramedic 2 adrenaline study, 9.4% of the survivors, 9.4% had presented in shockable rhythms and only 0.5% presented in non-shockable rhythms. So almost a 20-fold difference in terms of survival. So it's really those in shockable rhythms who are likely to survive. So that defibrillation is particularly important in terms of optimizing survival. As I'm sure you're all aware, it's very time dependent, and for every minute's delay in defibrillation, outcome falls by about 10%. Which is why, with ambulance services struggling to get to patients promptly, there's been a lot more focus on bystander CPR and bystander defibrillation. If we just have the next slide, please. Thank you. So the emphasis on bystander defibrillation, on bystander CPR has moved on now just from not only chest compressions, but of course, early defibrillation as well. And in systems that can deliver both, there is a real potential for very significant increases in overall outcome. The challenge, of course, is educating bystanders and having enough defibrillators available for them to use. But in systems where it's available, then it can make a big difference in terms of outcome. Perhaps we can talk about that in a bit more detail in a few minutes. Next slide, please. In terms of the ALS side of things, you'll all be familiar with the algorithm. The three things I just quickly wanted to mention. There's been a lot of debate which is discussed in more detail in the actual guidelines themselves about optimal energy levels and how often shock should be given. There's surprisingly little information out there on which to base our recommendations, but generally speaking, it's felt that probably a minimum of 150 joules is optimal for the initial shock. In terms of what you do after that initial shock, if you need to deliver other shocks, then the guidelines recommend that certainly if you've got a manual defibrillator and it's capable of escalating energy levels, then it's reasonable to escalate the output of the defibrillator if that's possible for subsequent shocks. If not, a fixed protocol is absolutely fine because there's no real evidence that one strategy is better than the other. And finally, those of you who are old enough to remember, such as myself, in the past we used to have 3 shocks before moving on to the actual rest of the loop. We now, certainly with biphasic defibrillators, have updated that to just 1 shock. Biphasic defibrillators are generally much more effective, and it's felt that if that initial shock fails to terminate the shockable rhythm, then the optimal treatment is probably another 2 minutes of chest compressions before attempting again. Thank you. Next slide, please. I did quickly want to mention defibrillator pad position. So there have been a number of studies over the last few years suggesting that although people do put the sternal pad in the correct place, the apical pad under the armpit tends to be placed too low and too medially. And as a result, probably the electrical current between the 2 pads doesn't transect the heart. And certainly in the current guidelines that we're updating, we're going to be emphasizing the need to put the apical pad in the correct place. So it needs to be in the mid-axillary line and essentially just below the armpit, but it's quite lateral on the side of the chest wall. I am sure that by paying attention to correct pad position, it will optimize shock success. And finally, just talking about pad position, if I could have the next slide, please. There's been quite a lot of discussion over the last year or two about what's been called dual or double sequential defibrillation. So that's essentially putting on 2 pairs of defibrillation pads and firing both defibs together. These are the results of a recent meta-analysis that we did through ILCOR. And essentially, there is no evidence, certainly with the studies that are out there, that dual sequential defibrillation improves overall outcome. In fact, there are 1 or 2 soft amounts of evidence in the literature suggesting that it may actually cause more harm than good. So for the time being, until results of larger randomized studies are out, we certainly don't recommend dual sequential defibrillation. So last slide, please. So in summary, defibrillation obviously is a time-critical procedure and needs to be done as soon as possible in the resuscitation sequence. The aim is to terminate VF and restore a perfusing rhythm. Defibrillation, of course, isn't successful if it's asystole that you get, it's the perfusing rhythm that you're after. 150 joules for the initial shock, and then escalates, if possible, for refractory VF. We haven't really had time to talk about children, but 4 joules per kilo for children. Pad position is very important in terms of optimizing outcome success, and dual sequential defibrillation currently of unproven benefit. Thank you.
Thank you very much, Charles. Before I ask you any questions, there's quite a lot on the Slido on the questions. And there's also, for the audience watching, if you go up there and hit polls, there is a poll question about double sequence defibrillation, whether you should use it, not use it, only in research, or you don't use the manual defib. So please do click on your thoughts on that. And there's quite a lot of questions on the Slido. And so the first one was, and I'll combine a few questions, is because an AED is often already used before the manual defib gets there, should we be moving towards just giving the shock at the highest energy level rather than just escalating?
So I'm assuming that's implying that despite the initial shocks, the patient's on VF. So
but even if you didn't know, why do we start at a lower energy if we know a higher energy might be better?
So,
that's the question.
Yeah, one of the fallacies with defibrillation is that more isn't necessarily better. And the current energy levels are designed to give just enough electricity to terminate the shockable rhythm, but not so much that the heart is stunned and remains in asystole. So yeah, there is evidence that with higher energy levels, you may well be more successful in terminating your shockable rhythm. But if you terminate it into asystole, that's really no great advantage. So there's certainly a couple of interesting studies that have come out in the last year or so, suggesting that outcomes worse if you go straight for higher energy levels. And it may well be because all you do is achieve myocardial stunning rather than leave the heart in a state where it's able to restore spontaneous circulation. So to some extent, the energy levels that we recommend at the moment are cautious, but starting off with just what is necessary to achieve return of spontaneous circulation and no more.
Great. That'll answer about 4 of the questions on the Slido, because there's quite a few about energy levels. One of the other questions, and I think it would be worth just clarifying this, in that someone's asked, what do you mean by double sequence defibrillation? And I'm not always quite sure what people have done when they've done these studies. So tell us a bit more about it.
Okay. Well, I would just ask if people can have a look at the full talk, then I do talk about it in quite a lot more detail. But just briefly, it involves putting the first pair of pads on, usually anterolaterally, as I showed in the earlier slide, and then a second pair of pads either alongside those or in some studies positioned front to back, so that you basically end up giving 2 shocks, one anterolaterally and the other front to back. So most studies have aimed for the defibrillators to discharge synchronously together. So you end up pressing both buttons on two defibrillators together. So you effectively get double the amount of electricity, and often delivered in two different vectors if you're using anterolateral and anteroposterior pads. So one vector across the heart and one vector going from front to back with the current. There is some suggestion that using those two different vectors may, in theory at least, improve defibrillation success.
And are people meant to press both buttons at the same time, or one after the other, or?
Well, I wouldn't say people are meant to do anything in terms of dual sequential. Some studies have aimed that with two defibs you press the buttons together. Other studies have separated the firing of the defibs just by a second or two. So you fire one, then the other very quickly. There is at least one case report where two defibrillators were fired together, where the output from one destroyed the second defibrillator. So it's not without its risks for the other defibrillator as well. So I think it is actually very difficult to time exactly to the millisecond both defibrillator discharges, so there's exactly the same time. And it's difficult in the studies to know whether the shocks were delivered exactly on top of each other or just within a few milliseconds separation. So there's a lot of variability in terms of what's actually clinically delivered.
Okay. There's quite a few questions on here, and I was just going to pick one of these out in that some people have asked about the role of drugs and, and specifically beta blockers such as esmolol when you have refractory VF. So, the combination of the shock plus drugs. Just a few words, and then we're going to have to move on, and we may have time at the end of the session to answer some more, but just one more point.
Yeah, well, certainly in terms of refractory VF, it can be quite a challenge to treat. And so, the first thing in terms of treating refractory VF is to make sure your defib pad's in the correct position. I wouldn't go for dual sequential defibrillation, and beta blockers, particularly esmolol, have been used in a few studies. There haven't been any sort of prospective randomized high quality studies, but there have been a few intriguing small cohort studies suggesting that esmolol may be of benefit in patients with refractory VF, possibly by helping attenuate this sort of sympathetic storm that may or may not have been induced by repeated adrenaline doses, for example. So I know one or two EMS systems are introducing esmolol into their armamentarium of drugs for treating refractory VF. Whether it actually does affect outcome or not beneficially remains to be seen. But certainly in terms of what's out in the literature, esmolol may possibly be of benefit in treating some of these quite difficult cases.
Okay. So it's not in the ERC guideline draft, and so those people who want to comment on it can go on the ERC website and comment and feedback. I'm going to thank you, Charles, for the time being. When you started your talk, a lot of people were voting for double sequence defibrillation, but you've changed your mind. So most people say no, only in a trial. And the number of people who wanted to use it has halved or less than half. So well done. And I'm going to hand over to Kate now. Thank you.
All right, thank you. So I'm very happy to introduce our next speaker, who's Dr. Jerry Nolan, well known to many, I'm sure. He's a consultant in anesthesia and intensive care in Bath in the United Kingdom, and has had in the past probably more leadership roles than I could possibly remember to list in ERC and ILCOR. So welcome, Jerry. Thank you.
Okay, thanks very much for that kind introduction. I'll see if I can hopefully share my screen for you. Any luck? I'm hoping you're seeing that. Yes, you are, because I can see it on my other screen. As ever, the full talk is sort of at the bottom of your screen, so I encourage you to go and have a look at this, because this is just going to be just a few highlights on this. What I think is actually quite a hot topic now of intraosseous versus intravenous access for cardiac arrest. We've got, I think, quite a bit of data being accumulated on this. There's a couple of important principles I want to get across, and one is that we generally think that if adrenaline is effective, and I think there's evidence now from the Paramedic 2 trial certainly of increased survival with adrenaline, that if it's going to be effective, it may be that it's more effective given earlier. And this is a sub-study from the Paramedic 2 trial that's been recently published. I know it's a complex slide to show very quickly, but the gist of it is, if we look over here, this is A over here is probability of ROSC with time, and you can see time across the bottom. And you've got the adrenaline arm of this trial. Remember, this was a blinded trial. The adrenaline arm, the kind of pinky color, and placebo in the bluey cover. And in essence, as you go down, you get a decrease in rate of ROSC of about 4% for every minute delay in giving adrenaline. And if you look at B over here, you get basically in terms of 30-day survival, it's about a 10% reduction per minute delay in giving adrenaline. So if there was a way of giving adrenaline more rapidly in cardiac arrest, maybe it would result in better outcomes. And that's the kind of gist behind the idea of giving IO. And you may say, well, what's the evidence that IO is going to be any quicker than an intravenous route? The best study we've got showing this is this, and it's one of the few randomized controlled trials actually of IV versus IO, and it compared 3 groups in out-of-hospital cardiac arrest: humeral IO, tibial IO, and peripheral IV, as you can see there. And their primary outcome was initial success rate in terms of access to the circulation. You can see here tibial was significantly higher success rate, and especially when you also take into account secondary displacement rates, the tibial route was particularly effective, as you can see. Less so in terms of successful placement was humeral. I might say more about that in a moment. So if we believe this study, it's possible that tibial route will enable faster delivery of adrenaline and therefore potentially better outcomes. Now, the problem is when you look at all the data that we've got out there, it's largely observational. In fact, it's pretty well purely observational data in terms of survival. This is from a recent systematic review. It's done on behalf of ILCOR, and these are all the observational studies that have been published. You can see them listed down the side. And in the red box, we come over to here is survival of hospital discharge. The intervention here is something to do with IO, either successful placement of IO, a successful IO, or an IO attempt, I should say, first versus IV, or successful initial IO. And if you scan down here, pretty well all of the time, every single study shows that IO is worse in terms of the raw data. But the problem, of course, with that is that in many, many systems, paramedics and other pre-hospital providers are encouraged to attempt IV first, and may only attempt IO if they failed an IV or where they think the patient is going to be very difficult, and where then they would use IO first. So in virtually all of these studies, you see certainly a reduction in an initial rhythm of VF or VT in the IO group. Nearly always the IO group gets later delivery of the drug because, of course, it's done as later on in the process. There are more women, for example, in the IO group because they're often more difficult. And there's fewer witnessed arrests in the IO group. So everything is biasing up against the IO group in these observational trials. We've now got some sub-studies, well, 2 specifically. This is from the Paramedic 2 trial, and these data have just been published in Intensive Care Medicine. And I know it's, again, a horribly complex slide to show you very quickly, but if you look at the ROSC at hand over here, and what we're doing is looking at the difference between placebo and adrenaline. IV route is here, and the IO route is, IO route is here. And you can see the odds ratio for those 2 different routes are identical. So, impressively 4 times. You have 4 times the rate of chances of achieving ROSC rather than a hospital handover with adrenaline versus placebo. And it's identical whether it's IV or IO, which suggests from this study that it's just as effective given by those 2 routes, everything else being even and accounted for. These are data from the ALPS trial, which is the other study where there's been a sub-analysis looking at IV and IO. And it's actually showing much the same thing, although the trend here seems to favor IV route. In other words, if you look at the IV versus IO, you've got slightly better outcomes with the IV group. But there is, if you look at the interaction statistics down the side, you can see these overlap completely, and it's not significantly different. So this is the treatment recommendation from ILCOR, and of course this has been included in the recent ILCOR COSTAR paper. It was published a couple of days ago, and this is the recommendation here. So we're still suggesting IV access as compared with IO for the first attempt for drug administration during adult cardiac arrest. But then if attempts at IV access are unsuccessful, or IV or it's deemed to be not feasible, we suggest IO access as a reasonable attempt. So I've just taken this is my summary slide from the main talk. So there's a couple of points on there that I haven't addressed in this very brief summary. I think the key thing is that animal pharmacokinetic data suggests that sternal and humoral routes are actually pretty similar to IV. Although interestingly, despite what I've said about speed of access with the tibial route, it may not enable the same concentration of drugs to be delivered. So that's something which we need to look into. And as I've just shown you, the paramedic 2 suggested an absolutely identical effect, so 4 times odds ratio, whether it be IV or IO for ROSC, whereas the ALPS trial suggested that IV may be more effective, but that was not a statistically significant difference if you looked at the interaction. Tibial IO may be faster than IV, and I think that's key. And as I've said, faster access may shorten the time to giving adrenaline, and our secondary analysis from paramedic 2 suggests that that will improve outcomes. And I think the absolute key take-home message here is the bottom bullet there. We clearly need a randomized controlled trial looking at these 2 routes in cardiac arrest. And that's the only way I think we're going to actually answer this question. I'll stop there. I'm very happy to take any questions.
Thank you very much, Jerry. There's a lot of questions popping up. I think I feel like this data is so difficult to decipher because, you know, IVs seem better than IOs for getting the drugs in there, but they take longer to get. And then humeral versus tibial, again, you have pros and cons pushing the results in different directions. So confusing to know what to do.
It's really confounded, isn't it? That's the problem.
Yes. So I have one question here. Is there an explanation why early placebo medication also seemed associated with better outcomes?
Yeah, well, of course, if this is the whole point about having to do these randomized trials, because of course, the longer you're in cardiac arrest for, then the less your chances of both getting ROSC and of surviving. And of course, therefore, if there are any sort of intervention that's time related, is going to show a bias if it takes a longer time to do that intervention. And that's been very well described by Lars Anderson in his paper on resuscitation time bias. And I think that really underlines the whole problem, trying to tease out what is an effect of the intervention itself versus simply because it's given later in the process.
Right. There are, I think, several questions on the Slido getting at the general question of basically how hard should you try for an IV before you go to an IO?
Well, that's what we don't know. I mean, what we do know at the moment is that it varies around the world. So I can say in the UK at the moment, standard guidelines are for there to be 2 IV attempts before the paramedics will try IO. However, with the rider, that if it really looks totally impossible, they can go IO first. I am aware, and Kate, you will know this better than me, but I know that there are some EMS systems in the US where they are already going IO first as a matter of routine. And I didn't show the slide, but that ALPS sub-study was very interesting because there were, you know, about half the EMS systems, I think, contributed all of the IO patients to that trial. Some of them where more than half the patients were getting IO compared with IV. I didn't say it, but for the paramedic 2 trial, which covered a lot of the United Kingdom, it was about 30% that ended up with an IO route. So we're only going to be able to do this with a randomized trial, which I think is going to be challenging to deliver because, of course, it's impossible to be blinded doing that.
Right. Do you know if there's any such trial in planning or in progress?
I couldn't possibly say.
Mm-hmm.
Professor Perkins. I mean, yeah, yes is the short answer. There may be more than one even, actually.
Okay. Let's see. So some of these other questions are more about medications and epinephrine than so much about the route. Someone did ask a question, which they prefaced by saying, difficult question. Said, did you hear about the Ezio tool with problems of losing power without warning? Or do you have any specific thoughts on like which devices are more or less reliable? I don't know if you can answer.
So I do know something a little bit. So the EasyIO issue with batteries, and forgive me if I get my facts completely wrong, but the issue I think was to actually test the battery is quite difficult. The only way you can test it is to sort of check every so often by putting it on and firing it up. And of course, you then run the battery down when you're doing all these checks. I think they've got around that with a light system or something on it now to enable that to be checked without too much power loss. But I'm sure somebody from industry or somebody out there will tell me I'm wrong. And you can put it in the Slido, please, if you think that I've got that wrong. But they've definitely addressed that issue now.
Okay. Let's see. Then someone asked a question about that the decreasing survival with increasing time of epi administration would indicate establishing an IVIO and giving epi before advanced airway. It's the recommendation. I think that's.
Well, I mean, that's a very fair comment. I mean, I don't think we've necessarily got the data to totally prove that, but I would suggest to you that the suggestions and recommendations that we've made both in ILCOR and in the HA and the ERC draft guidelines are kind of pushing that direction anyway, because we're certainly suggesting that advanced airway probably should be delayed, because we don't seem to see an advantage in that. And almost by definition, therefore, there are other things we can do. I still think, though, I would not want to overemphasize the benefit of drugs in cardiopulmonary resuscitation. It's still about high quality CPR, early defibrillation, for example. I think drugs are always going to be secondary to those interventions, even if we can give them more rapidly via an IO route, for example.
Right. Someone did respond to the EasyIO. It said when battery life, there's a red light warning when battery life is 10% or less. And then if you do, sorry, the questions are moving while I'm reading them. And then if you do lose power, you can put the needle in manually, which I have not done that myself.
Good. And thank you for that answer. I was vaguely in the right direction. I just wasn't 100%. I know, because we had an issue locally in the hospital trying to sort this out.
All right. Let's see. I think, Jess, should we move on given the time? I think you're muted, Jess.
Yes, let's move on, and Jerry can look at the questions on the online panel and type in some answers. So we're going to move on to our final speaker. It's Susanna Price. She's a cardiologist intensivist at the Royal Brompton in London, and she has a special expertise in echocardiography and was the recent chair of the acute cardiac group of the European Society of Cardiology. Thank you, Suzanne.
Great. Can you see my slides okay?
Yes, we can.
Great, fantastic. So I'm just going to talk a little bit about focused cardiac ultrasound. I'll be very brief. Just to put it into context for those of you who don't use this or haven't seen it used, if you're faced with a cardiac arrest and you're thinking about your reversible causes, so generally I'd be saying you're not focusing on your defib now, you're thinking about your oxygen and your hypokalemia, those your 4Hs, 4Ts. If you use what's immediately available to you in most emergency departments or pre-hospital setting, you can tell that the patient's hypothermic or hypoxic very easily. You can add in with an arterial blood gas or some blood sampling and a chest radiograph, you can say whether they've got a tension pneumothorax or not. This is just looking at adjuncts. And then if you add in a focused cardiac ultrasound, you then can actually address 7 out of the 8 4Hs and 4Ts. So you can recognize or not profound hypovolemia. If you've got a big dilated right heart and the history is suggestive, it may be a pulmonary embolism, and you may be able to recognize a pericardial collection. And then you can use your focused cardiac ultrasound to guide your intervention. I think the problem for me is that if people get focused on doing their scans during an ALS algorithm, they may take their eye off the ball with respect to delivering high quality CPR. So they may take too much time, hands off the chest, they may delay interventions that are proven a benefit. And so we really have to have systems in place and training programs in place to make sure that this isn't a problem for our patients and we're not causing them harm. So if you look at the recommendations that currently as they stand, there are no recommendations for how people should be trained in focused cardiac ultrasound. These two quite nice studies looked at training programs, and the second one actually was a 6-month training program, but they showed that with that you could achieve the images you wanted and interpret them within the hands-off pulse check, rhythm check time. I think the other thing that's been highlighted by a number of studies that it's not just about training the person who's doing the scans, it's making sure the rest of the team are aware that just give me another moment to get some more images is not acceptable during an ALS algorithm. And then there are some practicalities. So this was just published this year, looking at trying to really turn it into a very standardized algorithm where you absolutely minimize hands-off time on the chest, but you can incorporate focused cardiac ultrasound provided the team are trained. And what these the authors here talked about also was who should interpret the ultrasound, which has been a bit of a bone of contention amongst many groups. But they've made some recommendations, and I think it's an interesting concept, and standardization absolutely is key, and that the whole team know how to use it appropriately. They don't have to be able to do it, but they should know how it should be used. So that's practicalities about using focused cardiac ultrasound. What about, can it help us in decision making other than that you've got a collection or probably a pulmonary embolism? There was a bit of an enthusiasm to say we should use the absence of coordinated cardiac activity to stop resuscitation efforts. And the evidence that's being gathered now is, yes, it may be associated with a worse outcome. In fact, it probably is that you have cardiac standstill, but you shouldn't use focused cardiac ultrasound alone to decide whether you're going to cease resuscitation efforts, because it doesn't mean that your patient will definitely not survive. So rather it should be used as something to spur you on if you have ongoing coordinated cardiac activity. If you think it's PEA, but actually it's just profound shock, you should be resuscitating that patient very, very aggressively. And then what about echocardiography and ultrasound in post-resuscitation care? Well, there's no study anywhere that shows that any kind of echocardiography has ever been linked with an improvement in outcome. It's a diagnostic and potentially monitoring tool. However, if you're going to deliver high quality post-resuscitation care and you've had a cardiac arrest, you do need an expert to take a look at the heart and see if they can tell you how to optimize the cardiac output if it's possible, determine whether there's anything potentially reversible that needs to be addressed in the immediate post-cardiac arrest setting, and then guide you into more advanced critical care, up to and including extracorporeal support if you need it. So echocardiography isn't just for during the arrest, where it should be used as a focused rule in, rule out, but actually very experienced echocardiographers can really help manage your patients on the crit care afterwards. So I think in summary, focused cardiac ultrasound can provide useful information, but you do need to be trained to use it. You do need to be able to be trained to interpret it. The team need to know how it should be used appropriately. You shouldn't use it on its own to stop resuscitation. And if you're going to do post-resuscitation care really well, you need to befriend an expert echocardiographer. So there's my summary for you.
Thank you very much, Susanna. There's lots of questions on the Slido again on this, and I'll start with some that I've got. One of them is how, so you can do the course on getting the images, but how everybody ultimately now, these handheld devices are becoming easier to obtain, cheaper, and they'll probably end up taking over from the stethoscope at some stage. And how much training do you need? What's the minimum to use one of these things?
Well, it depends whether you want to just be able to acquire the images, or if you want to be able to acquire them, interpret them, and apply what you've got. I think it's not difficult to teach somebody to get 2D focused cardiac ultrasound images. The difficulty is interpreting them, and also then being able to get them that are meaningful within the time frame you've got. So if you're a non-expert, the best study there was that last one that was a 6-month training program, where they actually demonstrated both of those things, all three things were feasible. They could get the images, they could interpret them, and they could acquire the images within the time frame that was allowed during ALS. The last paper which looked at the how you position people around the bed and how you highly protocolize it, they were suggesting actually that the person who takes the echo images or the focused cardiac ultrasound images shouldn't be the person interpreting them at all. Other people would take the view that actually they should, and the rest of the resuscitation team should focus on resuscitating. So I think we don't know, and we absolutely don't know how many scans it takes for people to achieve that level of skill. And I think certainly in cardiology, we're moving now from numbers and duration of training time to entrustable professional activities. And I think this absolutely lends itself to an entrustable professional activity, and you'll be able to practice it up to that particular level.
Sure. And there's some questions about what's the role of TOE as opposed to transthoracic?
So the advantage of transesophageal echo obviously is that you're nowhere near the chest when you're looking at your images. It has significant disadvantages to it. It's not without risk. You're in a cardiac arrest setting. If you're not set up to use transesophageal echo, it's very distracting, and you're up by the airway, interfering potentially with what your anaesthetist is doing. Some of the earlier studies actually did suggest that TOE may be the most useful. And I think it will be interesting to see whether the very small microprobes may be better than the actually quite large still transesophageal echo probes that we've got. The information you get is the same. I mean, it's just the image displayed in a different way. It's just a question of how do you want to integrate that into your resuscitation algorithm? Is it better to have the person at the head of the bed spending a bit of time putting a TOE probe down? And that's not without risks as well. Or is it better to just approach the chest from the front from a subcostal view and get intermittent images? Biggest advantage of TOE is then, of course, it becomes continuous.
Quite a few questions about pulmonary embolism and right ventricular dilatation, and that there have been studies that show in nearly everybody who arrests, it's quite common to see a big right heart. So how do you work out it's a PE or not? It's
a really good question. The problem with the right heart is twofold. Firstly, when you're looking at on the surface of it, it looks really easy, doesn't it? The right heart's big. You may have had a pulmonary embolism. If you see clot in transit, that's you've won. You know exactly what's going on, but that's really unusual. And then the other problem is that many of our patients have comorbidities. And one of the things that the right heart does in response to pulmonary disease is it dilates. So you may mistakenly be thinking that you're seeing a pulmonary embolism when actually you're just seeing a patient who has lung disease, who has a right heart that's being dilated for a significant period of time. So to just go on the size of the right ventricle alone, you can do it provided you really think that there's a high risk this patient has had a pulmonary embolism and you have excluded all other potential causes. But you have to put it where you can into the clinical context or you'll get it wrong.
Okay.
And just to add, the McConnell sign that was supposed to be very, very specific for pulmonary embolism, it isn't. You see it in right ventricular infarction as well. So just because you see preserved apical right ventricular function, it doesn't make it any more likely really that the patient's had a pulmonary embolism.
Okay, thank you. There's lots of general questions on here for the whole panel. So role of, and first of all, is there, Kate, do you have any questions for Susanna? I see she put up one of your papers, so, you know.
I was an editorial, but yeah. No, I think just with transesophageal, I think for believers in the transesophageal approach during CPR, the main advantage that I've seen people talk about is verifying correct hand placement for CPR, because you can actually do it, while CPR is ongoing. But yeah, it's not something that we do routinely. I was trying to see if there were any other questions that I think she's got to most of them. So, but yeah, like you said, there are some general questions that we could also, I think there were many questions on defibrillation too. We might be able to go back to a couple of those if we have a couple of minutes.
Okay, do you know what's the highest rank? So keep on, people can vote up questions on the thing. So if you want a question answered, give it a vote. Charles and Jerry's written about this, safety of defibrillation with oxygen and risk of fires. Yeah, it's always a hot topic in literally, but yeah, how often does it happen, and is it still a risk with pads instead of paddles?
Yeah, shall
I'll let Charles answer first.
Charles. Yeah.
Well, I hope we have the same opinion. Yeah, I mean, there is a significant risk and it's small, but when it does happen, it's quite spectacular, as Jerry will no doubt tell you. I mean, in terms of defibrillation, I think I'm right in saying that most of the sort of fires stroke explosions that have occurred in relation to defibrillation have been in confined spaces such as the back of an ambulance. Unless someone's going to correct me, I'm not aware of any cases where it's occurred, say, in a bigger emergency room where there's a bit more air and ventilation, but the risk is still there. So I think it is prudent to just be aware of the risk, and I think the guidelines are quite sensible in terms of what they recommend.
I think yeah, thanks, Charles. Of course, I agree with that. So firstly, yeah, I mean, I've not experienced a defibrillation related fire, but my colleagues have experienced a pretty horrific fire in the ITU from an oxygen cylinder. So it's certainly not something you want to see in healthcare. What I would say is that, to my knowledge, and I'm happy for people to enter into Slido if I got this wrong, virtually all the oxygen-related fires associated with defibrillation are quite old now and have been associated, as far as I know, exclusively with manual defibrillation, where with the risk of sparking. I'm not aware of any cases that have been associated with adhesive pads. I mean, Charles, correct me if I'm wrong, if you're aware of any, and if there's somebody out there that is aware of one. I don't think there's been any reports published that I've seen. So it is an interesting question, because it does beg the question is, are we being overly cautious in some of the things we're recommending when we're using, hands-off defibrillation? And I genuinely don't know the answer to that. We clearly want to veer towards the safe side, but I just suspect we may be being overly cautious a bit now.
The trouble is, we'll only know we're not being overly cautious.
I know, and I won't go into the details of our experience. You really don't want to have a fire involving oxygen.
Actually, it's interesting because obviously 21% oxygen and air, 24% oxygen doubles the rate of combustion, and 30% oxygen increases it tenfold. And certainly in the back of an ambulance, where I've done some studies measuring high flow oxygen, particularly with the Lucas device, the early Lucas devices that used to discharge 120 litres a minute, we were measuring 60% oxygen.
Yeah.
And I think somebody had also asked a similar question about a patient who arrests in the hospital on a ventilator, and how to think about the ventilator with defibrillation. I know we generally disconnect patients, but I think there are scenarios when not. Any specific insights there?
Yeah, Charles, do you want to do that for a while?
Okay, yeah. I think as long as the circuit's closed and there's no option around defib pads, that in terms of the option side of things is safe. The only thing with ventilation is that is obviously at end inspiration, when the chest is full of air, then it does increase the intrathoracic and transthoracic impedance. Biphasic defibs are better at dealing with that, but there is some evidence that higher impedances don't help shock success rates. So by disconnecting the ventilation and allowing the chest wall to collapse, reducing the impedance, it may improve defibrillation success.
Okay, we're coming to the end of our time, so I was just going to ask one out of the blue question for everybody. So some of you will have time. What's the next big thing in ALS? So Jerry, you go first while the others have a think about it.
Well, I'm going to be biased, and I'm going to say intraosseous access. No, but I'm sure that's not true. I do think some of in terms of advanced life support, some of the technology around the presentation that Suzanne has done, I think could be a bit of a game changer, because I think it will mean that even village idiots like me might be able to use these devices and actually then be of quite considerable use at the bedside immediately. So I would think that's probably quite an interesting thing. And then I'll leave Charles to answer them, because I think probably in areas of defibrillation there's going to be quite an advance as well, actually.
Teresa, what's the next big thing?
I think that we should be focus on the causes of the cardiac arrest. We do a lot of things to just get them out of the arrest, but we need to look at what caused the arrest, and that will be something for the future.
Okay, Susanna?
So I think that the way that artificial intelligence is now moving to be able to interpret images for us is going to be a big game changer, because then you're going to just get your answer in terms of what the heart's doing. But the thing that I think we should really be focusing on as well is predicting decline. I think we're looking at the wrong things, and that's why we're not able to tell which patients are getting sick and going, as it were, off piste. And I think there is a very exciting future to be had there to try to really use artificial intelligence and try and understand what signals are there that we're missing, we're just not seeing in these patients that are getting sicker. So those are the two areas that I'm really looking for. Okay,
and Charles?
I think in another 5 years' time, perhaps, we are going to be able to approach ALS very differently, in that with rather than the 2-minute cycles that it's based on, having to stop at the end of each 2 minutes, we don't need to do that anymore. With some of the ECG filtering technology that's out there, we can see what the underlying rhythm is while we're doing chest compressions. So when we get to the end of the 2 minutes, we don't need to stop. If it's VF, we can carry on shocking. If it's asystole, we give some more adrenaline. If it's an organized rhythm, we know whether it's ROSC or not from the end tidal CO2. So we could almost have a continuous approach to delivering ALS rather than this very artificial 2 minutes. We don't need to stop at the end of 2 minutes, because everything we're assessing, we can assess while we're carrying on.
Looks like lots of tailored boutique therapies. Kate, any final words or comments? Unmute yourself.
No, I think the thing that I'm most hoping to see in the in-hospital setting is learning better how to differentiate between, as one of the Q&A, one of the folks asked, between sort of the death spiral, a patient who's just dying and we can't stop it, and someone we can actually intervene on and save. And I think for in-hospital rest, a lot remains to be learned there.
Yeah, we probably need some sort of mitochondrial meter or something that tells you if the person's dying or just having a bad day. Thank you all very much for being a great panel, great session on ALS. Thank you all for listening. Go visit the exhibition, and there's lots of more great stuff on. So thank you all very much. Bye.
Thanks all. Bye.